Welcome to the deep dive. We had a request for some focused MSRA pediatric revision, so today we're tackling septic arthritis in children.
Yep, a really important one.
We've taken the septic arthritis and osteomyelitis review and basically pulled out all the high-yield stuff you need. Our mission today, equip you with the core info definitions, causes, risks, how to manage it all in a way that hopefully sticks for the exam.
Exactly. Let's make it clear and memorable. So starting right at the top. Definition. What is septic arthritis in kids?
Okay, so it's an infection, right, causing inflammation in a joint.
In a native joint, yeah, one they were born with. And critically, it's usually acute, comes on quickly.
Acute.
Got it.
And you mentioned it's crucial to treat it fast.
Absolutely. The whole point of jumping on it quickly is to preserve that joint's function. Delay can mean long-term damage, so time is really of the essence.
Okay, makes sense. So the clock's ticking. What actually triggers this infection? Let's talk etiology of the causes.
Right. Well, the main culprits are almost always bacteria, bacterial pathogens.
Okay. Any specific ones we should know for kids?
Definitely. There are sort of 4 big players you see most often in pediatrics. You should probably know these names.
Lay them on us.
Okay, so Staphylococcus aureus, that's a really common one. Then Streptococcus pneumonia, Haemophilus influenza used to be more common before the Hive vaccine, but still around, and Kingella kingae.
Kingella kingae. Interesting name.
It is, and increasingly recognized, especially in younger children. So those are the key ones to remember. Staph aureus, strep pneumo, H flu, Kingella.
Got it. The big 4. And how do these bacteria actually get into the joint?
Good question. The most common way is what we call haematogenous spread.
Meaning through the blood.
Exactly. Bacteria from somewhere else, maybe a little skin infection or an upper respiratory tract infection, they get into the bloodstream and travel, eventually seeding the joint.
Wow. So something seemingly unrelated can lead to this serious joint issue.
Precisely. Less often you might get direct inoculation.
Like from an injury.
Yeah, trauma that breaks the skin near the joint, or maybe during a medical procedure like a joint injection or surgery, although that's rarer in kids needing this kind of intervention.
Okay, so bloodstream is the main route.
Yeah.
Now, who's most at risk? Are there specific groups of children more likely to get this?
Yes, there are definitely risk factors. Age is a big one. Really young infants, particularly those under 3 months old, seem to be more vulnerable.
Okay, very young babies. Who else?
Children with compromised immune systems, so kids with immunodeficiency or those dealing with other chronic illnesses, their bodies just can't fight off infection as well.
That makes sense. What about recent illnesses?
Yeah, having had a recent infection like those respiratory or skin infections we mentioned can be a preceding factor.
Kind of primes the pump, maybe.
Sort of, yeah. Also, trauma to a joint or recent joint surgery like we touched on with direct inoculation.
Right.
And finally, some pre-existing conditions increase susceptibility. Things like sickle cell disease or certain rheumatologic disorders can make joints, well, a bit more prone to infection.
Okay, clear risk factors there. Let's get into the actual process inside the joint, the pathophysiology. What happens when those bacteria arrive?
Right, so the microorganisms invade the joint space. This immediately triggers a pretty intense inflammatory response from the body.
Inflammation. So swelling, pain.
Exactly. But it's more than just irritation. This inflammation, combined with toxins released by the bacteria, starts to actively damage the joint structures, the cartilage, even the bone underneath.
Ouch. Actual damage occurs.
Yes. And as the immune system sends in white blood cells to fight the bacteria, you get this accumulation of purulent material, basically pus, filling up the joint space.
So it becomes this contained bag of infection and inflammation.
Pretty much. And that leads directly to the key symptoms: significant pain, obvious swelling, and the child being really reluctant or unable to move the joint.
And you mentioned if it's not treated.
Yeah, that's the scary part. The infection isn't necessarily contained. It can spread to the surrounding tissues, like the bone causing osteomyelitis, or even get back into the bloodstream causing sepsis. Systemic complications. That's why speed is so vital.
Definitely underlines the urgency. Now, a kid comes in with a painful, swollen joint. It could be septic arthritis, but what else is on the list? What's the differential diagnosis?
The differentials. Yeah, you need to put your thinking cap on here because other things can look similar. First, you've got to consider primary rheumatological disorders.
Like juvenile arthritis.
Exactly, juvenile idiopathic arthritis, or JIA, even osteoarthritis, though less common in kids. Also things like vasculitis, inflammation of blood vessels. And while rarer in children, conditions like gout or pseudogout need to be, kept in the back of your mind.
Okay, so inflammatory conditions, what else?
Well, sometimes drugs can cause arthritis, drug-induced arthritis. Then there's reactive arthritis.
Reactive, meaning triggered by something else.
Yes, it can happen after an infection somewhere else in the body, like after certain gut infections, post-infectious diarrheal syndrome, or sometimes after meningococcal or gonococcal infections. Those are less common causes now. Even inflammatory bowel disease can sometimes be associated with arthritis.
So a reaction to a previous event. Any other infections that mimic it?
Oh, absolutely. Lyme disease is a classic one, especially if you're in an area with ticks.
Right, tick bites.
And various viruses can cause a temporary self-limiting viral arthritis. And don't forget, infective endocarditis infection of the heart valves can sometimes present with joint pains. So it's a broad list initially.
It really is. Requires careful history and examination. Let's talk numbers. How common is this condition? Epidemiology time.
Okay. Overall, thankfully, it's relatively uncommon. But because the consequences can be so severe, it's high stakes when it does occur.
Right. And is there a most common bacterial cause overall?
Yes. As we mentioned, Staphylococcus aureus consistently pops up as the most frequent bad guy across most studies.
Okay. And zooming in on the UK, specifically for MSRA prep, what are the key stats?
Right. For the UK context, the incidence is roughly estimated at around 4 to 5 cases per 100,000 children per year.
So not super common, but definitely something you'll encounter.
Exactly. And interestingly, it seems to affect boys more often than girls. The ratio is about 2 to 1 male to female.
2 to 1, boys more likely. Any particular joints favored?
Yes. The large weight-bearing joints of the lower limb are most common. Think hip, knee, and ankle. Those are the top 3.
Hip, knee, ankle. Okay, maybe a little mnemonic. HKA.
HKA, I like it. Hip, knee, ankle, the UK hotspots. Perfect.
Good. So we know who gets it and where. Now, what does it actually look like when a child presents? The clinical features, signs, and symptoms.
Okay, symptoms-wise, the big one is joint pain, often severe enough to cause a limp, or the child might just flat out refuse to use that limb or bear weight.
Right. Pain and non-weight bearing. What else?
Fever is very common. The child often appears systemically unwell, maybe lethargic, irritable, not interested in playing, decreased appetite.
So generally feeling rough. Maybe a mnemonic here too. Something like fever, irritability, limp.
FEL. Fever, irritability, limp. Yeah, that works. Good red flags to look for.
Okay. And what about signs on examination? What might we see or feel?
You'll often find the joint is visibly swollen, maybe red or erythematous, and definitely warm to the touch compared to the other side.
Swollen, red, warm. Classic signs of inflammation.
Exactly. And crucially, there's typically very limited movement at that joint, either actively or passively, because it hurts so much.
Okay. Any other important points about presentation?
Yeah, a few things. While it often hits just one joint monoarthritis, it can sometimes affect multiple joints. Also, while fever and rigors, shaking chills, are common, you can't rule it out just because the child doesn't have a high fever.
Ah, that's a key point. Absence of fever doesn't mean it's not septic arthritis.
Correct. Don't be falsely reassured. Sometimes you might see signs suggesting bacteria in the blood, bacteremia, like the child being really unwell, maybe prostrate, vomiting, even hypotensive in severe cases. And presentation varies by joint. A septic hip might just present as refusal to walk, whereas a septic knee might be more obviously swollen. And this is vital, especially in babies and toddlers. The localizing signs might be really subtle.
Subtle how?
Like, the joint itself might not look dramatically red or swollen, but the child just screams if you try to move their leg, or they hold it in a funny position and won't put weight on it. You might just feel a bit of warmth or see very slight swelling. Reduced mobility and stiffness are pretty constant, though. So maintain a high index of suspicion, even if the signs aren't textbook obvious.
High suspicion is key, especially with subtle signs in little ones. Okay, we suspect it. How do we confirm it? Investigations.
Right. The absolute cornerstone, the most important investigation, is analyzing the joint fluid. You have to get fluid out of the joint.
Arthrocentesis.
Yes, arthrocentesis. That fluid needs to be sent for analysis, cell count, gram stain, culture. That's how you identify the organism and confirm it's an infection. It's the gold standard.
Gold standard. Joint fluid. What else backs that up?
Blood cultures are essential. Take at least 2 sets from different sites. You want to see if the bacteria are also in the bloodstream. Plus, Basic blood tests.
Like a full blood count.
Yep, a CBC, looking for a raised white cell count, and inflammatory markers, CRP and ESR. They are usually significantly elevated in septic arthritis. Very helpful markers.
High CRP and ESR. Okay. What about imaging? Does that help?
Imaging plays a role, but maybe not always right at the beginning. X-rays are often done, but they might look normal early on. They're better for looking for complications later, like osteomyelitis or bony changes.
So X-ray might be normal initially. What else?
Ultrasound is really useful, actually. It's great for detecting joint effusions, the fluid buildup, even small ones, and it can help guide the needle if you're doing an arthrocentesis, especially for deeper joints like the hip.
Ultrasound for fluid and guidance. Okay.
For more detail, especially if you're worried about abscesses or spread to the bone, then CT or even better, MRI scans are the most sensitive. They give a much clearer picture of the soft tissues and bone marrow.
CT and MRI for complications. Any other scans?
Occasionally, radionuclide bone scans might be used. They can highlight areas of inflammation and can be useful if it's hard to pinpoint the location, maybe in the pelvis or sacroiliac joints.
Okay. And back to that joint fluid analysis, what exactly are we looking for?
So you send it for a white cell count, usually very high in septic arthritis, a gram stain to get an early clue about the type of bacteria, microscopy to look for crystals, which helps rule out things like gout, and critically, culture to grow the bacteria and find out exactly what it is and what antibiotics it's sensitive to.
Culture is key for targeted treatment.
Absolutely. In some cases, if you suspect unusual infections like fungal or TB, you might send synovial tissue for culture too. And PCR tests can sometimes detect bacterial DNA, which might be helpful if cultures are negative after antibiotics have been started, for example.
PCR, useful sometimes. Anything else?
Well, if the story suggests Lyme disease, you'd order specific Lyme tests. And if you're strongly considering a rheumatological cause, then relevant immunology tests might be needed.
Right, tailoring the tests. Now, you mentioned something earlier, the Kocher criteria. Useful for MSRA, I think.
Yes, the Kocher criteria, definitely worth knowing, especially for suspected septic hip in children. It's a set of 4 clinical and lab findings.
What are they?
Okay, think FNNW, that was your mnemonic, wasn't it?
Oh, yeah, FNNW.
Right, so F is for fever greater than 38.5 Celsius. N is for non-weight bearing on the affected leg.
Right.
Another N for neutrophils, technically a raised white cell count, usually over 12,000. And W, wait, hang on.
FNNW, fever, non-weight bearing, raised WCC, what was the last one?
ISR, right. Raised ESR, usually over 40 millimeter is often quoted, though some use 20. Sorry, got tangled there. Fever 38.5, non-weight bearing, WCC 12,000, and ESR 40. The more of those criteria the child meets, the higher the probability it's septic arthritis of the hip.
FNNW fever, non-weight bearing, raised WCC, raised ESR. Got it. A useful predictive tool for hip cases. Okay, diagnosis is made or strongly suspected. How do we manage it?
Management needs to be fast and aggressive. The 2 main pillars are prompt intravenous antibiotics and drainage of the infected joint.
5E antibiotics and drainage.
Yes. Sometimes surgical intervention is needed for the drainage part.
Okay, let's break that down. What about the specifics for septic arthritis?
For the joint itself, surgical drainage and lavage, basically washing out the joint surgically, is often necessary, especially for the hip, or if there's thick pus, or if the patient isn't improving quickly with just antibiotics and maybe needle aspiration.
A washout might be needed. And the antibiotics.
High-dose 4V antibiotics are essential. You start them empirically, meaning based on the most likely bacteria for the child's age and the gram stain result, if available, even before you get the final culture results back.
Start treatment before you know the exact bug.
Yes, you have to. Time is too critical. You choose broad-spectrum antibiotics initially, guided by the clinical picture and local resistance patterns. Common choices might include flucloxacillin, perhaps with cefotaxime or ceftriaxone, or clindamycin if there's penicillin allergy. Vancomycin might be used if MRSA is suspected.
Okay, broad cover initially.
Exactly. Then, once the culture results come back, you can tailor the antibiotics to the specific organism identified. If it involves a prosthetic joint, which is rare in kids but possible, you absolutely need specialist orthopedic input.
Right. How long do they need antibiotics for?
It's a long course. Typically IV antibiotics for at least a few days to a week, maybe longer depending on response, followed by oral antibiotics. The total duration is usually somewhere in the range of, say, 4 to 6 weeks, maybe sometimes longer for bone involvement.
Wow, 4 to 6 weeks. That's significant. Any other medical treatments?
Well, if the child isn't getting better after about, say, 5 days of appropriate antibiotics and drainage, you need to seriously reassess. Is it the right diagnosis? Is the drainage adequate? Is there resistant bacteria? You might need to re-aspirate the joint.
Reevaluate if no response.
Definitely. You might re-examine the fluid for crystals again, just in case. If you suspect those rarer fungal or mycobacterial infections, a synovial biopsy might be considered then. The role of adding corticosteroids is still debated and not standard practice.
Okay. And the joint drainage you mentioned, surgical washout. Are there other ways?
Yes. If there's a significant effusion but maybe not needing immediate surgery, repeated needle aspirations can be done to remove the pus. Ultrasound guidance can be really helpful here, especially for the hip or if the fluid is loculated, meaning trapped in pockets.
So repeated taps or surgery.
Right. And if needle aspirations aren't enough for certain joints like the hip, then open surgical drainage is often the way to go.
And what about keeping the joint still? Splinting.
Yes, splinting the limb is usually recommended, certainly in the early painful phase. It should be splinted in a functional position. This helps with pain control, might protect the healing cartilage, and importantly, prevents the joint from stiffening up in a bad position, prevents contractures.
Okay, splinting for comfort and function. So it's a pretty intensive treatment. What's the outlook? What's a prognosis for these kids?
It varies. Unfortunately, there is still a mortality risk associated with septic arthritis, though much lower now with modern treatment. Maybe around 5–15%, but it really depends on the bacteria, the child's overall health, and how quickly treatment was started.
So it could still be life-threatening.
Yeah.
What about joint function long-term?
Functional recovery depends heavily on the bug and the damage done. For Staph aureus infections, maybe around half of children regain completely normal joint function.
Only half for Staph aureus. That's quite sobering.
It is. The outlook is often better for others, like pneumococcal arthritis, where maybe up to 90 and 95% can recover full function if treated promptly. But complications do happen.
How often?
About a third of cases might experience some kind of complication. These are more likely in older patients if there was already joint disease or if diagnosis and treatment were delayed.
And what sort of complications are we talking about?
Well, the infection can destroy the joint cartilage, leading to chronic pain and arthritis down the line. It can cause joint deformities or affect limb growth, leading to length discrepancies. There's the risk of systemic spread sepsis, which we mentioned.
That's just right.
Osteomyelitis infection spread into the adjacent bone is a major concern. And you can get abscess formation in or around the joint. In the worst cases, though rare now, it could lead to amputation or the need for joint fusion surgery later in life.
So a whole range of potential long-term issues, maybe another mnemonic for complications, DJSOAP. DJSOAP.
Let's see. D for destruction joint, J for joint deformity chronic arthritis, S for sepsis, O for osteomyelitis, A for abscess, P for persistent pain or poor function.
Yeah, something like that. Destruction, joint issues, sepsis, osteomyelitis, abscess, persistent problems. Covers the main ones.
DJSOP. I like it. It really highlights why getting this right early is so critical.
Absolutely. Okay, let's try and summarize the key takeaways for everyone revising pediatric septic arthritis for the MSRA.
Right. So remember, it's an acute bacterial infection of a native joint. Needs rapid diagnosis and treatment to preserve function.
Key causes. The big four: Staph aureus, Strep pneumo, H. flu, Kingella. Spread is usually haematogenous.
Risk factors. Very young age, 3 months, immunocompromised, recent infections, trauma, sickle cell.
Physiology. Bacterial invasion leads to inflammation, pus, and cartilage bone damage.
Differentials are broad. Think JIA, reactive arthritis, Lyme, viral, osteomyelitis.
Epidemiology in the UK. 4 to 5 per 100,000 kids year. MF is 2.1. Common joints are hip, knee, ankle, HKA.
Clinical features. Think FIL fever, irritability, linked non-weight bearing. Look for a swollen, red, warm, tender joint with restricted movement. Remember, signs can be subtle in infants.
Investigations. Joint fluid analysis, arthrocentesis, is gold standard. WCC, Graham culture. Bloods show high WCC, CRP, ESR. Blood cultures needed. Ultrasound helps detect fluid. MRI for complications.
Don't forget the Kocher criteria for hip, FNNW fever 38.5, non-weight bearing, WCC 12K, ESR 40.
Management. Urgent few antibiotics, empirical then tailored. And joint drainage, aspiration or surgical washout. Splinting helps.
Prognosis. Variable, better with prompt treatment. Staph aureus has poorer functional outcomes. Complications, DJ-SOAP, occur in about a third joint destruction: sepsis, osteomyelitis, abscess, persistent pain problems.
Excellent summary. I think the absolute key message for anyone listening who's preparing for MSRA is that high index of suspicion, especially with subtle signs in young children, followed by prompt investigation and aggressive management. It's just non-negotiable. It saves joints and potentially lives.
Couldn't agree more. That early clinical suspicion is everything. Don't wait if you think it might be septic arthritis.
Absolutely. Well, hopefully this deep dive has been useful for your revision. For more MSRA support, remember to check out PassThemSRA.com and also FreeMSRA.com for loads of great resources.
Yeah, definitely worth looking at.
Thanks for joining us on the deep dive.